So as Tony mentioned, I'm a cultural anthropologist as well as a psychiatrist. And I've actually found addiction to be the perfect topic to study as a psychiatrist and cultural anthropologist, because at least in the US, we have no cultural consensus about what kind of problem addiction is. Is it, for instance, a moral, spiritual problem? And that was definitely the perspective of the evangelist ministers that I studied in Puerto Rico, and to whom I brought Utox kits and a breathalyzer, thanks to Tony George for a clinical outcome study. Is it a problem of neuroreceptors and genetics and predisposition? Is it a problem of post-industrial social conditions, unemployment, the rise of international narco-traffic in the wake of legal jobs? So these are interpretations that we're still working through in the United States, and often the same person will talk about addiction in one valence, one moment, and in another moment. So it's really the perfect topic for cultural anthropologists, and in addition, someone like myself who actually attempts to treat addiction and to see addiction in all of these terms. So layered onto this cultural complexity of addiction is the role that race plays in addiction and in drug policy in the United States, where race is a central organizing principle. So across the border, as you know, our economy was founded on legally and socially enforced racial segregation, in which we've long had a second-class labor force of blacks and migrants from various places. And that labor force has produced goods for an exclusive white consumer market. So this dynamic, it actually persists today. I don't know if I should put my computer here, but it's a dynamic that persists today in illegal drug markets, in narco-traffic. If you only take a second to think about Colombian grown and produced heroin and cocaine and its travel across Mexican border, and as I talk about in my Puerto Rican work, the Puerto Rican border or Puerto Rican crossing point of the United States, and all of the racial hierarchy that's built into international drug trade and who does the most dangerous labor in illegal drug markets. Today, I'm also going to argue that that dynamic persists in biomedical industries. And I'm going to share a case study of hidden yet active maintenance of white exclusivity in medicine in the US as a cause of what we often call, quote unquote, health disparities among underserved minorities. So we describe these disparities in a kind of a passive manner as applying to people who lack access to care. And today, because I'm in front of a group of healthcare providers, I want to argue that it's not in the US as passive as it might seem. We usually take whiteness for granted in the US. We rarely examine whiteness as something that requires cultural enforcement, that in itself creates an environment, an extreme environment driving social patterns of addiction and health. So whiteness is central to our environment of profit motives, commodification, and the use of racial hierarchies to segment and open markets. It involves mutual racialization of drugs and of people, in that drugs can be white, as in targeted to white people, and they can pharmaceutically enhance the whiteness of people whose privilege is in question because of stigmatizing diagnoses like addiction. So I'm going to be drawing from my forthcoming book on white opioids to shed light on the racialization of narcotics. For over a century, narcotics have upheld US racial segregation in terms of prohibitionist policy versus protected legal pharmaceutical markets for a white middle class. And they guard racial boundaries and hierarchies of deservedness and moral blame. They tap into our, and when I say our, I'm talking about the US context. Again, I'm really curious as to how this maps onto Canada or doesn't. But these dynamics tap into our conflicting cultural logics about whether addiction is moral, social, or biological. They're also major drivers of the economy and of national politics. So for instance, in the US, we consume 80% of the world's opioid supply, opiates and opioids together. We have less than 5% of the world's population. Billions of our US tax dollars are being dedicated each year to the drug war, enforcing the drug war and its policies in Latin America and also in the inner cities. So while narcotics have long been criminalized through association with marginal racial groups, such as turn-of-the-century images, oops, the arrows? Okay, here we are. There we are. Turn-of-the-century images of Chinese opium dens, cocaine-crazed Negroes in the south of the US, and Mexican marijuana madness. We don't often look at how this can work in the opposite direction, how a drug becomes unmarked, how it can assume whiteness within a racialized pharmaceutical logic. And yet this process of pharmaceutical whiteness is at the core of a widely asked question in the US. Why is the life expectancy of whites suddenly falling? I don't know if you're familiar with this article that came out in the annals of the National Academy of Sciences. Why is the life expectancy of whites suddenly falling while the life expectancy of almost every other racial group in the US is rising? And how did opioids become their primary immediate cause of death? So this is of excess death. This is a question that's prompted a national discourse on the endangered white male, which actually I think has played a role in our national election, our last national election in the US. So my answer to this question of how opioid overdose became white is going to be different than the received wisdom that unemployed whites in the post-industrial Rust Belt of the US turned to opioids for solace, for their pain, their psychic pain. That may be true, but it begs the question of why opioids, why white people, and why now? So I'm going to argue that the current generation of opioids were designed to have white racial identities, and that in our stratified healthcare and justice systems, the biotechnologies and social technologies shaping opioid consumption reinforce racial inequalities while at the same time harming whites. So I encountered, let me just go back for a moment. Okay. I encountered these technologies of opioids, both the biological and social technologies of opioids in the late 1990s. This is when I was, when Tony George was my research advisor and sending me into the field with urine toxicology kits. I was also working a clinic on Wednesday evenings at Yale where my attendings were running clinical trials, early clinical trials of a new pharmaceutical for opioid dependence called Buprenorphine, which would later get the commercial name suboxone. My supervisors were excited about Buprenorphine, which they said was about to change the culture of medicine by making addiction a mainstream chronic biological illness, treatable alongside diabetes, hypertension, and asthma in the same primary care clinics and in the same way, with long-term pharmaceutical maintenance. So I have to take a second to explain office-based buprenorphine treatment in the US, because I have learned in my trip here that actually buprenorphine is not office-based, primary care office-based in the same way in Canada. So the legal structure is quite different, and the history and the politics are quite different. But in buprenorphine, in the US, buprenorphine can be prescribed by any certified physician out of a private practice, out of an office-based setting. So I was working in this clinic, working on these clinical trials in the same time, in the late 1990s, as the rise of the prescription opioid use in the suburbs. So this is just one of the articles that ran shortly after this, when opioids became the most prescribed drug class in the US. An overdose followed closely behind. All of this was happening in the midst of a national move towards stop and frisk and sting operations in Black and Latino inner city neighborhoods that led to unprecedented incarceration rates. So let's see, I'll get back to that cartoon. So that put the US prison population well above all other countries in the world. I'd found a puzzle. Increasing white opioid use in the midst of an intensified inner city drug war. And this puzzle has become a part of my study of addiction pharmaceuticals, for which I've observed dozens of drug policy and addiction science meetings, observed interactions in clinics over 4 years, and interviewed almost 200 addiction scientists, treatment advocates, pharmaceutical executives, policymakers, administrators, prescribers, and patients. Before I go to the next section, I just want to come back to this slide. How many of you are aware of the 1986 Anti-Drug Abuse Act in the United States? I see a few hands. Okay, so news of that did get across the border. That's the act that mandated minimum sentencing for possession of 1/100th the weight of crack cocaine as opposed to powder cocaine, completely ignoring the chemical similarities between the two drugs. And it's the law that did the most to increase incarceration rates in the US and disproportionately incarcerate African American and Latino people in the United States. And I think what you'll see as I go into my story is that there may be an analogous situation that evolved in the early 2000s with regard to drug law enforcement for prescription opioids, non-medical use versus heroin. All right, so I'm going to give you the punchline up front from my study. In my research, I discovered an unrecognized form of ethnic marketing that, because it targets white people, works by not marking itself as racial. The story is invisible by design. It was only through sustained participant observation and interviews with key participants that I've been able to unravel these threads. So I'll start with suboxone in telling the story of race and opioids in the opioid crisis, because that was my starting point. 20 years ago, working in this clinic that was doing the clinical trials of buprenorphine, otherwise known as suboxone. It's easiest to see its racial identity by comparing it to its predecessor, methadone. And that's what this slide about. In the United States, methadone is the only other opioid that can legally be used to treat opiate addiction. And here is a bar graph from the first and last nationally representative study in the US to compare buprenorphine patients to methadone patients by race and class. You'll see here that buprenorphine patients are much more likely to be white in this study, much more likely to be employed at baseline and have some college education. And I updated this data in New York City, doing mapping of the residential zip code of people receiving methadone versus people receiving buprenorphine. And what you'll notice from this map, I've continued to update it, is that the pattern is almost the inverse. So in the New York City area, you'll see Staten Island on the lower right-hand side, which is a predominantly white and suburban, higher income borough of New York City. That's where the suboxone is being prescribed. And methadone, on the other hand, is being prescribed in upper Manhattan neighborhoods such as Harlem and the Bronx. So all of this confirms the pattern of methadone versus suboxone by neighborhood, race, and income. But what we don't know from these graphs is by what process have these two medications, buprenorphine on the one hand and methadone on the other, gained their racial identities? So I'm going to tell a slightly historical story now. Let's go back to 1965. Race riots have burned through Harlem, Philadelphia, and Watts, Los Angeles. The unemployment rate for blacks is twice that of whites. The mafia gains control of Asian heroin imports and recruits a sales force from black and Latino inner cities. Meanwhile, Rockefeller University diabetes researcher Vincent Dole, who thinks of heroin addiction as opiate receptor deficiency analogous to insulin deficiency in diabetes, publishes his findings from the first clinical trial of methadone maintenance. The study's subjects are African American heroin-injecting men from Harlem, and its outcomes of decreased criminal activity and increased employment at 6 months brings it national attention. By 1970, news of methadone as a pharmacological solution to urban heroin reaches President Nixon, who appoints pioneering methadone psychiatrist Jerome Jaffe as the nation's first drug czar. Jaffe targets inner-city blacks and Latinos, as well as returning Vietnam veterans, with methadone, the major weapon in Nixon's war on drugs. In order to prevent diversion and street sale of methadone, the DEA regulates methadone clinics, requiring daily observed dosing and regular urine testing. And these are actually regulations that persist today. Due to community resistance, clinics are located in marginal neighborhoods in the city, remote from other medical services. So let's fast forward to October 8th, 2002. A new kind of opiate problem has developed following Purdue Pharmaceuticals' aggressive marketing of OxyContin as quote-unquote minimally addictive as a pain reliever. Most of these newly addicted people are white, and many of them middle to upper income. The FDA has just approved the synthetic opiate buprenorphine, commercially packaged as suboxone, for maintenance treatment of opiate dependence in private buprenorphine-certified doctors' offices. Pharmacologically similar to methadone, in that it blocks opiate receptors in the brains of addicted patients, buprenorphine can be prescribed monthly from home or for use at home, while methadone is restricted to DEA clinics with their directly observed dosing. So we call it office-based buprenorphine in the United States. And it represents a reversal of national policy. So in the US, it's the first time since the 1914 Harrison Act that generalist doctors are permitted to use opioids to treat opiate addiction in their offices. To accomplish this legal and policy feat, the manufacturers of buprenorphine and the architects of buprenorphine policy had to distinguish buprenorphine symbolically and spatially from methadone. So buprenorphine, pharmacologically in the same drug class as methadone, had to be whitened. I'm going to attempt to show a public service announcement, otherwise known as an ad, by the manufacturer of suboxone, buprenorphine, Reckitt Benckiser. Let's see if this works. Okay, great. So this is the website, National Alliance for the Advocates of Buprenorphine Treatment. It's actually funded by Reckitt Benckiser Pharma. And let's try to open Mike's story.
My name is Mike. Played football in high school, sang in the church choir, and classic American opera. I used to look at people who used and abused drugs as people who were making a choice. They chose to do that. How could it happen to me? In 1999, we were remodeling our restaurant, and somehow I hurt myself. Our family doctor put me on painkillers, took an as directed. By the time 2004 came, my life was just completely a mess. My body could see 70, 80, 100 without thinking about it. I felt guilt, I felt shame, I felt dirty. This disease devours your total being. I had to get better. Not just did I find a tool that would work for me, but I found one that would let me continue my life. Being able to visit a doctor like an ordinary patient has made all the difference in the world in my recovery.
Okay. All right, so I wanted you to see the ad to invite you to do a reading of the ad in terms of, thank you, of race and class. And I'll give you my reading because it's, I think, very US specific. So Mike is seated in his Ohio diner. He's a diner owner, flanked by American flags, and talking of his return to coaching his son's baseball team, singing in his church choir after buprenorphine rescued him from a prescription opioid habit following a back injury. So this ad is stacked with a lot of images of white America, apple pie, middle white America. He's an average Mike. But I argue that the ad was just the tip of the iceberg, that the whiteness of buprenorphine that ads like this were cultivating was actively achieved by a number of different social technologies. And I'll give you my analysis of the contemporary US white opioid crisis in terms of what I call technologies of whiteness. That is, social technologies such as neuroscience, policy, and industry strategies that maintain racial boundaries around biomedical uses of opioids. My scheme is informed by whiteness studies, which is an offshoot of critical race theory, which is a branch of social science and humanities studies of race in the US. It proposes that 1, whiteness is a category of exclusion and therefore requires cultural and political maintenance of its boundaries. 2, white race is unmarked. As the assumed norm, it's rarely explicitly named, either in public policies or in the media. This also relates to a colorblind ideology that reproduces white privilege by eliminating racial references from seemingly universal policies and practice. So the term colorblind ideology I'm borrowing from critical race theorists such as Michelle Alexander, who wrote The New Jim Crow about race and mass incarceration. So she's arguing that laws such as the 1986 Drug Abuse Act in the midst of the crack epidemic that I just described, they don't mention race anywhere in the law, but they are clearly aimed at certain neighborhoods, racialized neighborhoods in the United States. So 3, whiteness is defined by its other. In the United States, white and black/other are interdependent. Punitive American drug policy has long had a mutually defining twin of legal narcotics for whites who have access to personal doctors, starting with morphine and over-the-counter heroin for middle-class Victorian housewives, and then moving to post-World War II barbiturates, stimulant diet pills, and Valium, otherwise known as suburban mother's little helper, now back to prescription opioid pain relievers. And then 4th, white privilege has its costs. Not only do US white consumers pay inflated prices for patented prescription opioids, they pay with their lives in the form of overdose by lethal substances to which they have quote-unquote privileged access. So the 4 technologies of whiteness that I'll be discussing include addiction neuroscience, new biotechnologies, regulatory structures, and marketing. I'll start with the least visible technology of race making, and that's brain science. Let's place buprenorphine development on the backdrop of President Bush I's decade of the brain. This was an era in which NIDA, National Institutes of Drug Abuse in the United States, was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. Alan Leshner, who was then director of NIDA, lobbied to rebrand addiction as a quote-unquote chronic relapsing brain disease. Leshner's ambition was shared by other leading NIDA researchers, who co-authored a widely cited article in JAMA in the year 2000 with the title Drug Dependence, a Chronic Medical Illness. In it, they argued that narcotics addiction was comparable to diabetes, hypertension, and asthma in terms of heritability, treatment adherence, and relapse rates, and as such, it should be treated that way. The scientists involved in this movement had a social justice intent. They wanted to destigmatize addiction by demonstrating that it's a legitimate biological condition. What they didn't see was that scientific universalism, with its implicit assumption of a standard white male subject, and the unequal ways that biotechnologies are disseminated in the US, would actually enhance the social stratification of addiction. So for instance, brain imaging like this, by taking out the subject in his or her trappings of gender, race, and class from the image, actually by taking the offending organ out of its body altogether, symbolically convey an unmarked universality of addiction physiology as the primary cause for addiction and epidemiology. In neuroscience, addiction is further reduced to molecular action at neuroreceptors, which is the ultimate disembodiment of addiction. The apparent universality of this molecularized model implies an assumed white norm and excludes the social and political conditions that people live in from addiction. Ironically, the scientists involved wanted to counteract a punitive drug war mentality by erasing the social and racial foundations of drug use. So this was a neurobiological version of colorblind ideology, as I mentioned before, that unconsciously unmarked and whitened opioids by molecular means, paradoxically further racializing drug policy. This is Nor Volkow, current director of NIDA, with the offending organ out of the body. So the next technology of whiteness is new biotechnologies. Neuroscientists were unwitting accomplices to more consciously racial industrial strategies. Building on the neuroscientists' ideology of technological solutions to previously sociopolitical problems, in 1996, Purdue Pharmaceuticals got FDA approval for OxyContin as a quote-unquote minimally addictive opioid pain reliever suitable for chronic management of moderate pain. And this was based on its patented sustained release capsule technology, in which in theory lowered the reward for drug users by preventing an initial rush. At the same time, the National Joint Commission on Hospital Accreditation called for pain to be aggressively monitored and treated as the quote-unquote fifth vital sign. So this is along with respiratory rate, heart rate, blood pressure. And this led to widespread OxyContin prescription for moderate pain, such as that due to lower back injury. Of course, the model of addiction-proof biotechnology that Purdue Pharma was definitely promoting left out the social inventiveness of drug users. OxyContin users interested in a rush quickly learned to crush and snort and or inject oxycodone from the capsule, with oxycodone being twice as potent as morphine. What followed has been called a public health disaster, with vast industries of prescription pill mills cropping up across the country, followed by unprecedented opioid overdose rates. After steep increases in opioid misuse and overdose, public pressure mounted for intervention. So in August of 2010, just as the original patent on OxyContin ran out, Purdue Pharmaceuticals introduced its tamper-resistant, time-released formulation, embedding oxycodone into polymers that convert tablets into gummies should users attempt to crush and dissolve them. By keeping prices high and representing OxyContin as technologically sealed off from misuse, the manufacturer strove to keep OxyContin symbolically a step ahead of urban, non-white street markets. Another biotechnology developed specifically in response to white suburban and rural prescription opioid epidemic was buprenorphine itself. Commercially released in a combination pill with opioid antagonist naloxone and branded suboxone. Reckitt Benckiser Pharma promoted this combination as a smart drug. Although buprenorphine was an abusable opioid, the naloxone with which buprenorphine was combined caused withdrawal symptoms if injected, but not if dissolved under the tongue as prescribed, since naloxone could not be absorbed through the tongue. Buprenorphine also posed a lower risk of overdose death than other opioids due to the ceiling effect on its impact on respiratory rate. In the 1990s, NIDA subsidized Suboxone's manufacturer to test it for use in addiction treatment and sharply distinguished it from Methadone, lobbying Congress and the DEA to lower the abuse potential rating of Suboxone from Narcotics Schedule II, where OxyContin and Methadone fall, to Schedule III, along with common household products like codeine cough syrup. And this is what made it possible to prescribe Suboxone in generalist doctors' offices in the US. In a race and class stratified healthcare system, such as we have in the United States, where access to general doctors is limited, often to those who can pay, patented technology is designed for private office delivery in themselves encode white race and middle class. So the third technology of whiteness is regulation and legislation. Although by 2004, prescription opioids overtook heroin as the primary opiate of abuse in the US, the arrest rate for their illegal possession was 1/4 that for possession of heroin. Arrests for illegal sale of prescription drugs was less than 1/5 that of the arrest rate for selling heroin. Not coincidentally, the non-medical use of pain relievers was twice as high among whites in the United States as among blacks, while rates of heroin use among blacks, Latinos, and whites were almost identical. Since suburban and rural whites were not politically supportable targets for drug law enforcement, the DEA and other regulators focused their surveillance and enforcement on prescription opioid prescribers and suppliers. One sign of this has been the spread of prescription monitoring programs in the US. And that's been enacted in 49 out of 50 states. Half of them mandate prescriber participation with threats of loss of license and prosecution. So I'm a prescriber in New York State. If I prescribe an opioid or regulated narcotic to a patient without checking the database to see who else might be prescribing narcotics to that patient, I could be incarcerated and lose my license. So it's actually a huge shift in policy towards the prescribers in terms of enforcement. Returning to buprenorphine, otherwise known as Suboxone, the Drug Addiction Treatment Act data was passed by Congress in 2000, and it enabled any certified physician to prescribe Suboxone in the privacy of their office. In congressional debates leading to the passage of Data 2000, there's a clear emphasis on a quote-unquote new kind of user, one that's young, suburban, and quote-unquote not hardcore, implicitly white. So this is coded language, and in the United States we often use coded language in reference to white race. Alan Leshner, then director of NIDA, testified that buprenorphine is uniquely appropriate for a new kind of opioid user as opposed to methadone, quote unquote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction. In the same congressional hearing, Health and Human Services Director Donna Shalala notes that buprenorphine as an alternative to methadone would serve a new kind of addict, quote, including citizens who would not normally be associated with the term addiction. This again is coded language for white race. Data 2000 kept the methadone system intact and did nothing to alter the drug laws that mandated inner-city heroin users to prison, but it did create a new treatment track for those who had the resources to take advantage of it. To give additional assurance to the DEA, the Drug Enforcement Administration, I don't think I defined that buprenorphine wouldn't spill over into illicit markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, developed an 8-hour training certification course that was required for doctors to prescribe buprenorphine. It was the first and only prescription drug in the US to come with such a requirement. So I, as a psychiatrist, can prescribe the most toxic chemotherapy to a patient without certification, but buprenorphine requires an 8-hour training. Public sector doctors tell me that the certification requirement in itself is a major barrier to making buprenorphine available to low-income people, as public clinics don't provide time or incentives for their doctors to pursue certification, while prescribers in the private sector, at least in New York City, for example, can charge fees of up to $1,000 for a half-hour initial induction visit for buprenorphine. So the shortage of public sector buprenorphine prescribers, along with the cost of buprenorphine itself, $5 to $10 per strip, as opposed to 40 cents a dose of methadone, have kept buprenorphine in the private sector in the United States, largely, with some exceptions. Okay, and then the fourth technology of whiteness is ethnic marketing. OxyContin's legendary commercial success hinged on its designation as a quote-unquote minimally addictive opioid analgesic. When OxyContin was under review at the FDA, Purdue Pharma estimated the addictive potential of OxyContin to be less than 1%, based on testing among terminally ill cancer patients for a 3-month period. In 1996, the FDA accepted the claim that the addictive potential of OxyContin was less than 1% based on these trials, enabling Purdue to open an opioid market that had previously been restricted to those with severe acute pain, like post-surgical or cancer pain. So they were able to open a new, much larger market of patients with moderate chronic pain, including lower back pain. Hiring almost 700 drug representatives who canvassed a call list of nearly 100,000 physicians. Purdue targeted generalists in white, suburban, and rural areas that served patients that the public and the DEA did not think of as at high risk of addiction and drug trade. Purdue's strategy was successful. It led to a 10-fold increase in prescription opioids, prescribed opioids nationally, with disproportionate uptake of OxyContin and similar opioids by prescribers in white, suburban, and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. In a newspaper content analysis that I completed, I found that in contrast to articles about the criminality of Black and Latino drug users, suburbanites addicted to OxyContin are portrayed sympathetically in the media as victims of overprescription or as people struggling with real or existential pain. Ironically, Purdue's technological response to the first wave of white opioid overdose deaths, their tamper-resistant formulations of oxycodone, combined with new prescription monitoring programs, led many of these legal OxyContin users to look for heroin when pills became hard to get. And one consequence of this has been a whitening of the media coverage in the US of heroin users who had long been portrayed as Black or brown. So this is a school teacher who started on prescribed opioids for a painful condition and ended up injecting heroin in the bathroom of her school. And this is a college athlete who, again, started with opioid pain relievers and ended with heroin. So the targeted intervention for these new heroin users Buprenorphine, otherwise known as suboxone, was marketed to middle-class insured patients over the internet. Manufacturer-sponsored web-based public service announcements, like the one that you just watched, Mike's Story, featured white professionals and business owners on suboxone maintenance. And I invite you to look at the racial coding of this ad. This same website features a link to a suboxone prescriber locator service created by the Federal Substance Abuse and Mental Health Services Administration. So, browsers that are looking for suboxone or buprenorphine prescribers will put their zip code into this browser and generate a list of suboxone prescribers, most of them in private practice. These strategies created an exclusive yet lucrative segment of the market for suboxone, making it a blockbuster drug. So it quickly, by 2012, reached well over $1 billion in sales alone, second only to OxyContin, which in that year reported sales of $3 billion. So this racial segmentation of drug markets into licit and illicit, black and white, clinical and recreational, as dictated by the war on drugs, and by opioid manufacturers, creates a moving target of time-bound patents on new technologies targeting the white middle class. The forerunner in this cycle was Bayer Pharmaceuticals' very own heroin. Marketed as a non-addictive treatment for morphine addiction among middle-class Victorian housewives when it was released in 1898. Now, it could be otherwise. In France, where buprenorphine was adopted for generalist physician treatment of opiate dependence in 1996, it was billed not as a stigma-reducing agent for a middle-class market, but as a public health intervention to stem overdose and HIV transmission among largely low-income immigrant heroin injectors. Buprenorphine was widely adopted among primary care doctors in poor communities in a country with universal health care. And that's a theme I hope we can get to in the discussion, what universal health care means in France, perhaps in contrast to here. The opioid overdose rate in France dropped by 80% in the first 7 years after buprenorphine's approval. Contrast that with the US, where overdose rates have quadrupled in the first 10 years after buprenorphine's approval. Based on my fieldwork with white and non-white people trying to access buprenorphine and stay on buprenorphine maintenance, I suggest that the public health potential of buprenorphine is limited by our racially segregated and market-driven healthcare system, which orphans patients that have patchy insurance coverage and tenuous access to prescribers. The French example highlights alternatives to the binary of commercialized biomedical versus punitive law enforcement frames for drug policy. In the long run, we may be able to use the current moment of despair over white deaths in the US to build the case for less market-driven healthcare system, for public health and a public health and social determinants-based approach that highlights the damage to both whites and non-whites of our racialized industrialization of health. So in the short run, we need to shed light on the impact of unspoken racial politics of drugs through initiatives such as, and I'm working with colleagues at the Drug Policy Alliance on this, racial impact assessments of new drug policies that are introduced in the legislature, modeled after environmental impact assessments. We need proactive measures because in both the prevailing US frames of criminal justice and biomedicine, addiction is individualized and based on a logic of consumer choice, making systemic racialization hard to see and making it easy to maintain two tracks of narcotics policy, a clinical track for middle-class whites and a criminalized track for the rest. Racially segregated drug policies and lucrative prescription narcotic markets can only be sustained if there is a separate route to categorize and discipline drug use among whites, and that route must appear, at least on its face, to be race neutral. It has its costs that are borne by whites who pay those inflated prices for drugs and sometimes pay with their lives. The ambiguity of the Greek word pharmakon, its dual identity as medicine and poison, is exploited in this white war on drugs that wasn't in the US, in which unprecedented profits are made in the liminal space between licit and illicit sales, a space that's protected by its symbolic whiteness. Thank you.